Now. Let's get started. We're going to talk about compartment syndrome this morning. I thought it was an apropos topic just because we had a recent case of this in the hospital, and just to review the making the diagnosis, the management of this, and then we brought the catheters up just so you can see how to use them if you're ever called to assess someone and determine their compartment pressures. So what is compartment syndrome? It basically comes down to an injury to the muscles and the associated structures, nerves, contained within a fascial compartment. It results from decreased blood perfusion and tissue ischemia. And there are various different ways that this can develop the pathophysiology, and we have a little video explaining that. But basically what we have ischemia, swelling, and a rising tissue pressure, which leads to the muscle and tissue necrosis. And if untreated, what happens is the muscles scar in, result in contracture and significant deformity. So the history of this, when we hear of Volkmann's contracture, that's a word or an eponym that comes up on exams. This was first described by Volkmann back in 1881. And what it is described as this ischemic necrosis followed by contracture. And Volkmann described this in the level of the forearm. So what causes compartment syndrome? And there's a whole host of things that can do it. You can have kind of the external phenomenon or the internal phenomenon. So the external is if things are pushing down on the compartment, and something to think about is a tight circumferential dressing or cast. We've all seen this. Someone has a displaced wrist fracture, it's reduced, and then they're put in a cast. And then it doesn't necessarily go to compartment syndrome, but they call the office and they said their hand is markedly swollen, their fingers are numb, and the first thing you do is you split the cast. And my added point on this too is you also have to look at that soft roll, because sometimes that soft roll in itself can be tight. So I'll also cut the soft roll and just make sure that there's no pressure on it at all. And that's the one thing about the waterproof cast that we have, that Gore-Tex material, that's not very elastic. So I think that in itself could even cause swelling into the compartment. Then we talk about this extravasation of IV fluids, and this is the case I was associated with about 2 years ago, where the subcutaneous space gets so full that it puts downward pressure on the compartment. Things like dialysis, anticoagulation therapy, chemotherapy. And then you start to talk about the things that happen inside the compartment, and I think the biggest one on that is going to be intracompartmental hemorrhage. Fractures do it, crush injuries, excessive skeletal traction. We have a slide on that showing how the pressure goes up, or a deep muscle contusion. So those things, burns can also do it to kind of a secondary pathway, but all those things where you think the pressure is going to go up, somebody with a coagulation disorder, that's someone you really have to watch. So it basically turns into the next slide here, which is going to be our little video on this that explains how this is done. Hold on a minute.
Yeah, the pathophysiology, essentially you have decreased perfusion, right? So your perfusion to the tissues themselves is compromised. This sort of restriction.
It's not going to work.
pressure system. Pressure and equipment. Pressure outside. Pressure is out. Pressure is holding. This can be vascular resistance. Pressure. Also ischemic tissue breakdown. This can eventually vicious cycle.
All right, so I thought this is a friend of mine that I went to medical school with that has done a couple talks online. I thought that was good. But I think that the take-home point of this is it really starts on the venous side. And if you think that the venous pressure goes up, then that force gradient to perfuse the tissues from arterial to venous side is altered. The oxygenated blood, if you will, won't perfuse the tissues, and then eventually it'll back up and get the arterial side. So that the key point to this, how it applies clinically, is that someone can have compartment syndrome but still have pulses. So they still have pulses, their arterial side is still working at the time being, but the venous side is backed up. So the next question we have to ask is, somebody comes in and we think maybe having compartment syndrome, there's a delay to get to the operating room or whatever. What are some little tricks you can do? Is it better to raise the arm, lower the arm? And I think you can argue that either way. I think the right answer is probably just to keep it at heart level. Reason being is, what happens if you elevate it too high? Well, then it might be hard to arterially perfuse. What if you have it down low? That can increase the venous congestion. So the answer, I think, is just keep it at heart level. And one other thing that you could potentially do is you can increase the patient's blood pressure. If you increase the blood pressure, and this is a very short-term thing you can do because eventually it's going to go back and hurt you when things are very permeable on the venous side. But if you can increase the arterial pressure and keep that gradient high, and that would either be giving crystalloid or colloid, let's say in a trauma setting, you could potentially continue to perfuse that compartment and give you a couple hours if you need to get, additional personnel or you're waiting to go to the operating room. And then I'm going to go back to this. Here's kind of the whole schematic of the different things that are at play here. And it's a lot to look at, but I think the take home is that there are different mechanisms, all that converge on the common theme of the artery not being able to push the oxygenated blood out into the tissue. And like Sakib said, it is a kind of a reinforcing pathway that once this starts, you get increased permeability and it just continues on and spirals down. So there's that cycle we talked about. So originally, when you go back 30, 40 years, they were talking about an absolute pressure theory when someone had the amount of 30, and then another paper was at 45 when you started to get compartment syndrome. And the current theory now is it's more of a pressure gradient theory. So if you look at someone's diastolic pressure, if the compartment pressure is within 20 millimeters of mercury of that, then you might not be able to perfuse the compartment. And that's why I was saying you could potentially increase the patient's blood pressure to buy you a little bit of time. So what happens in terms of the tissue? You have a few hours where you'll get reversible changes, and that was 3 to 4 hours. And then up after about 8 hours, that's when it becomes irreversible. So if somebody comes in with suspected compartment syndrome and it's over 24 hours old, well, there's no point of doing it. It's like the damage is done. If they really had compartment syndrome, you're not going to improve them at all by doing a fasciotomy. And this is interesting in terms of nerve damage, because we always talk about the contracture in muscle, but nerve is just as big a player here, and I've certainly seen residual nerve defects after this potential compartment syndrome, and it happens really quickly. 2 hours, the nerve loses nerve conduction. You have a neuropraxic injury after 4 hours, and at 8 hours, it's irreversible. So how do we make the diagnosis? A lot of times it's clinical suspicion, the history of pain out of proportion to injury pattern, and this is a really good one in kids. After, let's say, you pin a supracondylar fracture, if they're requiring more analgesics in the postoperative period, let's say they're maybe taking Tylenol, they took 1 dose of Tylenol with codeine, and then suddenly mom's coming out and saying, we need more, something's going on. That has to alert you that a potential compartment syndrome is brewing. Tense, painful compartments, but that can come later. So you can't just go by, squeezing on the side. Decreased sensibility, muscle weakness, pain with passive stretch, and then the open fractures as well. You think, oh, it's open, the fluid can extravasate, but not necessarily, because it could just be a very small opening. And open fractures where there's a lot of muscle injury can have compartment syndromes as well. 6 to 9% is reported. So this is what I said, the increasing narcotic requirements. The pain is unrelenting, greater than expected. Removing the cast or bandages still doesn't help. And then the paresthesias, because the nerves are involved as well. Densely swollen compartment, and I make this point too, because when we talk about leg fasciotomy, that deep posterior compartment, you may not be able to readily assess that just by squeezing it. You're feeling kind of the gastrocsoleus complex, and then certainly you can feel the anterior compartment, but you might not be able to feel deep down. The 5 Ps, this comes up on the exams, pain on palpation or passive stretch, paresthesias, pallor, paralysis, and pulselessness usually comes last. So that's just another slide kind of showing the same thing. And the warnings here, to just kind of keep saying it again, the pulses are present early, and then you could even have normal capillary refill in the beginning. The damage is kind of happening at a cellular and below the scenes level before you see the systemic changes. So the clinical diagnosis, we talked about the critical compartment pressures. The compartment pressure of greater than 30 to 45 has to make you suspect something's going on. The resting pressure, I thought this was interesting. What's the resting pressure of the compartments? Like 0 to 5. So there is a little pressure in there, but it's minimal. And then the diastolic blood pressure within 20, when the diastolic minus the compartment pressure is less than 20, then you're worried about this happening. If it's equivocal, you want to do serial monitoring, and I brought a slit catheter that you can insert to kind of monitor a patient over 24 hours. In all honesty, with all the bad stuff that can happen, I think if I'm worried about monitoring this patient and it's equivocal, I'll probably just take him to the operating room and do the fasciotomy. And then down on the bottom, if you think about measuring the patient's compartments, you should be measuring them. It's better to err on the side of being more aggressive than less aggressive in this entity. So there are different ways of measuring the compartment pressure, and some of them are historical. We have the white sides, the wick catheter, a slit catheter, and then the Stryker device here. And then it's interesting in terms of the distance from the fracture site. So the highest pressures are going to be really close to where the fracture is. And then you want to be within 5 centimeters of that fracture site, because the compartment's very long, let's say in the leg, and you want to get it right close to where the problem is. So distance from the fracture site, you want to be closer to the fracture, which gives you a more precise and accurate measurement. And you have to go where it's, if it's high in one spot, well, it's high there, and then it could spread out. So here it is in terms of where the tissue pressure is, right at the level of the fracture site, and then you can kind of see this bell-type curve where the highest one is almost 40, and then within 5, you're still at a range which is somewhat worrisome. So this is the Stryker system. This is what we went to at the hospital and purchased this last year. That's what's in this white box, and then afterwards we can come play with this. Unfortunately, and this was probably the best part of me giving this lecture, was when I went through this tray, I found that the transducer is missing. So I spoke to Marcia, and she's ordering that. But we have the old system, which is the Synthi system, and it's good to know how to do that as well. That's like the slit catheter measurement, and I'll show you how to do that, just in case we need that for a backup. And I'll show you where this is and everything. But basically what it is you're going to put the needle into the compartment. You put just a little bit of saline to make this the same as the, I guess it's the interstitial pressure, and then you measure the compartment right off that. It's really easy and reproducible. So what's the treatment? Once you've diagnosed someone with compartment syndrome, the treatment's a fasciotomy. There's really nothing else that works here. It's a surgical treatment. The skin, fat, fascial layers, widely decompressed, and then initially left open. And then it's followed either by delayed primary closure, depending on the degree of injury, or a split thickness skin graft. The compartments that are just starting, maybe not even to the point where you need to measure them, but they're complaining of some tingling in their fingers. Well, the first thing is you're going to remove the circumferential dressings. I've seen this before where they univalve the cast. It doesn't work. I mean, they said it's a 30% reduction, but once you bivalve it, it seems that it works a whole lot better, and then you cut the cast padding, and that can take the pressure off like 55%. The elevation, like we said, because you could impact arterial perfusion, that's contraindicated here. This was an interesting slide in terms of the fasciotomies. So someone went in and, as they were surgically decompressing a compartment, measured the pressures and with each step of the operation. So when you just cut the skin, it didn't do a whole lot. Then when you did the fasciotomy, there was a marked decompression of the pressure. When you cut and it's a difficult word to say, but the epimysotomy, that is the covering over the level of the muscle. So over each muscle, you see, surgically, those of us that have been in the operating room, there is this kind of little fascial covering over that, but that had little effect on further decompression. So you don't have to go in and cut every muscle. You just have to make sure you open up all of the compartments. And in different places in the body, there are a different number of compartments, and we'll get to that. And then the skin closure, you can start to see that as they close the skin, even though before when you released the skin, it wasn't a problem because all the pressure's at the fascial layer. Then when you close the skin later, you can see that pressure starts to increase again. So that's why you leave these open, at least initially. So some of the places where you can get compartment syndrome, shoulder and humerus, forearm, hand, buttock, thigh, leg, and foot. I mean, this thigh, which I thought was unheard of, we actually had a case of this just a couple months ago. Most common right here in the leg, and probably followed by the forearm. So in the forearm, there are three compartments. There's a volar, dorsal, and then the mobile wad. And usually through two incisions, you can get to all three compartments. Where compartment syndrome usually happens is in the deep compartments. So when you see Volkmann's contracture, the muscles that are affected are your FVP and FPL and your pronator quadratus, because those are your deepest muscles of your volar compartment. And then your dorsal, you have your extensor musculature, your posterior interosseous nerve runs in here, and then your mobile wad. So the principles make the early diagnosis, long extensile incisions, and I think this is really important. When you see the fasciotomy and it's like 4 centimeters, I don't think that's enough. I think you can still have pressure throughout the compartment, so you want to do a nice long incision, release all the fascial compartments, neurovascular structures obviously preserved, necrotic tissue needs to go, and then the coverage in a timely fashion to prevent infection, coverage within 7 to 10 days. So here's a schematic of the forearm with this is kind of mid-forearm with all the muscles in there, and the key point being the FDP and your FPL are your deepest ones that kind of sit right on this intermuscular septum. And through this kind of dorsal incision, you can go both ways. A lot of different incisions listed in the literature in terms of releasing the volar forearm. And I think for me, the key, it's interesting because here, this one, it goes up lateral. This one, it goes up medial. Here we have like a zigzag incision. My big thing is I want to just make sure I have enough soft tissue to cover the median nerve. And this will usually be incorporated with a carpal tunnel release as well when we talk about the hand. But I want to make sure I have enough skin and subcutaneous tissue that I can mobilize and cover the nerve at least for about 2 centimeters proximal to the level of the wrist. Once you get past there, then you can get some covering of the muscle. And if I'm thinking about secondary closure, because I don't want to have to do a skin graft right on the level of the median nerve. So carpal tunnel is incorporated. You can either go up the radial or ulnar side and decompress the volar forearm that way. So here's just another picture of the volar Henry approach, which was chosen here, includes the carpal tunnel release, lacertus fibrosus, which is the terminal branches there of the biceps fascia, and you want to release that as well, and you want to go all the way up past the level of the elbow. So here's it's a great anatomical dissection when you get to do one of these things, because you can really see the whole forearm anatomy splayed out. You want to, of course, protect your nerves, your brachial artery, and your tendons. And then you're going to look at the dorsal side too and do release it there if needed. When you get into the hand, unfortunately, thank God I've never seen a hand compartment syndrome. The one I did kind of was mostly forearm, but extended there a little bit. But there are 10 compartments in the hand, and through 2 to 4 incisions, you can get all of the compartments. So there's the 4 dorsal interossei, 3 palmar interossei, the adductor, which is the hardest one to get to, and then your thenar and hypothenar. So here's just an example of 4 incisions that are used to get all the compartments. And a lot of times what happens is after you cut this fascia, you can kind of stick your hand in and bluntly dissect and just, make sure you get down and see everything right here. Here's your adductor pollicis, and this is the one that could be tricky to make sure you get all the way down to. But 2 dorsal incisions, one centered over the index, one centered over the 4th metacarpal, and then you can come from the sides to get your thenar and hypothenar area. Finger compartments, you can get compartment syndrome that goes into the level of the fingers, and the compartment is interesting here because you have these, thickened structures, your Grayson's and Cleland's ligament, and you can get just a localized compartment syndrome of your artery and nerve, which sit in here. So the procedure for that is you're going to make your midlateral incision, you're going to release your Cleland's ligament, kind of push your neurovascular bundle out of the way, sweep next to the tendon because the tendon is going to be adherent to the bone, and then come out here and release your Cleveland's ligament on the opposite side to decompress this other neurovascular bundle. So when we get down to the level of the thigh, you have your anterior, posterior, and adductor compartments. With the thigh, you can release this through a lateral incision, and then you go anterior and posterior off that. And then depending on if your adductor is tight, you will do a small medial incision as well. The leg compartments, and this is where it's most common. Tibia fracture is the one to remember with compartment syndrome. You have your anterior, lateral, superficial posterior, and your deep posterior compartments. And this is a nice schematic of the different compartments and the muscles that lay within them. In terms of compartment syndrome, tibia fractures, the most common one is the anterior compartment. And you can palpate that just right off the lateral side of the tibia here. Here's your lateral compartment with your perineals, your superficial posterior, which is gastrocsoleus, and then your deep posterior, which is the tricky one to get to all the way at the bottom. So we used to do the 2-incision technique, but now what's more common is to do a 1-incision technique where you can get all 4 compartments through just a long lateral approach. And it's a long lateral incision just anterior to the fibula. Here you can see the leg prepped out, fibula marked off, and your incision, which is just anterior to that. So here is what happens after you go through the skin and subcutaneous tissue, and you can see the dividing line. You're going to make a transverse incision right here just so you can determine where your anterior compartment is and your lateral compartment is. You don't want to be, slicing all up and down. So once you find that and you find the dividing line, you're still going to have to divide both, but gives you an idea of where to make that first longitudinal incision. So this is going to be our anterior, and then here's going to be your perineal tendons, your lateral. And then you go ahead and you release that entire compartment. You perform the fasciotomy of the anterior compartment, and the danger is right down here, which is your superficial perineal nerve. Your superficial perineal nerve runs in your lateral compartment, but about 2/3 of the way down the leg, it becomes subcutaneous and then goes to perform the innervation of the dorsolateral aspect of the foot. So you can't just this is where you get in trouble with your small incision, and then you're just going to run your scissors all the way down. You're going to bag that nerve. So it makes sense to open it up and then identify your superficial perineal nerve. You can see that right here, and then you can go ahead and kind of release on either side of it and finish your anterior compartment release. And then there's just an example of the superficial perineal nerve. So lateral compartment is next. You're kind of looking right at it there, and then it is standing up here looking under these retractors. And then what you're going to do to get to the back, to your posterior compartment, you're going to elevate your perineals, which are under your Army Navies, and then you're going to see the intermuscular septum. And underneath that is going to be your gastrocsoleus complex, depending on where you are relative to the leg. So gastrocsoleus is going to be right there. And then there's just an example of the gastrocsoleus fascia being released. So now we need to go in and find our deep posterior compartment. So again, anterior is our lateral compartment. Posterior is going to be our superficial posterior compartment. And then there is going to be the fascia for our deep posterior compartment. So the perifibular approach to the deep posterior compartment, you can see anterior is going to be your perineals, posterior is going to be your superficial posterior compartment, and then where the FHL is, that's going to be your plane in order to get to the deep structures, and then again, that's where your neurovascular bundle is. And then there's that last slide where he's performing the fasciotomy of the deep posterior compartment. And then here's just dressing of the wound afterwards. You see that can't be closed. You can see the external fixer in the picture, so there must be some sort of skeletal trauma as well. Integra makes sense here to close it. VAC coverage can be used. I'll show you an example of something I did where I take the rubber bands. They're the vessel loops, and I'll swing that back and forth to put tension on the wound. And if it looks too tight, we could always take that off up on the floor. But then you're going to come back and you're going to do your either delayed primary closure or your split thickness skin grafting in a short period of time. So down into the foot, and again, thank God I've never had to do this, but there are 4 main compartments in the foot. Your interosseous, your lateral, your medial, and your central. And just finding this online, it looks like there's 2 different ways you can do a foot fasciotomy. Similar to the hand, where you can make your incisions over the 2nd and 4th metatarsals and work down and kind of bluntly dissect to make sure you get into each of these compartments. And then the other way being kind of a medial approach, where you slip under the metatarsal and then work in here and then release appropriately. And it probably depends exactly on where they're the most tense and where you feel most comfortable with the anatomy. And then here's just a slide of the interim coverage techniques. Some people will use the wound vac. Some people will close a portion of this. Just be careful with that, and then apply some sort of coverage. This is the elastic band type technique, where you weave that back and forth, and then you can pull or loosen tension depending on what your final product is. And sometimes this is nice because it'd be easier if you're thinking of potentially coming back to close this wound. Keeping some tension on the skin will allow you to come back and be able to mobilize this at a short period of time to get the wound closed. And that's that vessel bootlace that is described down here. So aftercare, the wound's not closed initially. Depending on the nature of the injury, if there is necrotic tissue, you're going to do a second look with debridement. And then the definitive coverage for infection purposes 7 to 10 days later. So here's a little video. I think this is good too, because this is going to just kind of show the steps of an open fasciotomy. And I'm just going to escape out of this and see if I can.
Way to decompress an acute compartment syndrome is by a surgical fasciotomy. Now, if it's missed, you're convinced that it's long gone missed, and that sometimes is a difficult thing to know. How do you know when the clock started? Sometimes you don't know. This is very difficult in certain patients, such as patients kind of found down due to drug or alcohol intoxication, and sometimes you don't know when they started getting the compartment syndrome. So, but it can be argued that if it's already missed and it's long gone, then there's nothing to save. You actually might make things more complicated by opening up an arm full of dead muscle. So here's a cross-section of the lower leg. Now, essentially, there's 2 ways to do a 4-compartment fasciotomy. You can do it with a single incision, or you can do it with 2 incisions. Personally, I usually do it with 2 incisions, but one way or the other, you have to release all 4 compartments. Typical case of acute compartment syndrome in the lower leg. And there's sometimes unusual or rare cases where you only have 1 compartment completely involved, but nothing else involved at all, or, like I said, exertional compartment syndrome. But in most cases, you're looking to release all 4 compartments. So one incision fasciotomy is a direct lateral incision. It's a long incision over the lateral aspect of the leg. And better just kind of go to the pictures here. It's pretty much centered over the fibula, right, over the lateral compartment. You make a long extensile incision, opens lateral compartment, then you have to make a flap, right, and then you open the anterior compartment. You could try to go through the intermuscular septum. That's an option. You just be very careful of the superficial perineal nerve, which can be crossing your field. Or you just make a separate incision in the anterior compartment. I feel like there is a slide in here. So what you then need to do is bring this flap posteriorly, and then you get into the superficial posterior compartment, right? and then you also have to then make your way into the deep posterior compartment. So you basically go at the level of the fibula to get the lateral compartment, make a flap, go anterior to the fibula to get the anterior compartment, and then make another flap, go posterior to the fibula to get into the superficial and deep posterior compartments. Okay? So single incision. Now, there was an alternative to go through the intramuscular septum here to get into the superficial posterior compartment. So you come laterally here, and then instead of making a separate incision here under the flap, you can kind of come through and open the fascia this way. Okay? What about the two-incision technique? So two-incision technique, similar incision laterally, then you make a counter-incision on the medial side, something like this. Right? This is nicely shown here. So
if I were to do it, this is the way I'm doing it because I think it's so much easier.
Incision helps you, you go through your skin incision, raise a flap, you go through the anterior and lateral compartments. And then sometimes you can actually also, open the compartment through the intramuscular septum to go both ways. And then make a separate incision medially, right? Posterior to the tibia, here's the tibia, so you go posterior to the tibia, and then you go into the superficial posterior compartment, and then into the deep posterior compartment. And oftentimes, I don't like the way this is shown here with the deep posterior compartment. Skin, a lot of times, superficial posterior compartment is like this, and you have to move that out of the way to get into the deep posterior compartment. So, two longitudinal incisions. You definitely should have a skin braid. There shouldn't be any way you're bringing these two incisions close to each other. The lateral incision is, of course, centered between the lateral and anterior compartments. What you can see shown here, red pen. Sorry, it's not showing. So what you can see here.
All right. So I just wanted you guys to be aware of the one incision technique and then the two incision technique, and that's what I was just saying as Saket was talking there, is that the ones I've done the two incision technique because it's high pressure situation, you're nervous as can be, and at least I don't have as much comfort with the lower leg in terms of making sure I'm getting it all the way down to that deep posterior. You guys have any comments on that in terms of one or two, or hopefully it never happens? Yeah. Okay. Okay. Not as much. Okay. So complications, I think the biggest thing is you do an incomplete decompression. You kind of cheat and you're not super sure, either want to save the skin and you don't fully decompress it, or the other thing is you delayed or missed the diagnosis, and we have that kind of 8-hour window that we're playing with, and then you have your secondary complications here. This just kind of repeats what we talked about before in terms of the peripheral nerve injury, how quickly you can have problems with that, and then the skeletal muscle injury where you have kind of that 3 to 4 hour window, but then after 8 hours, it's really bad. The other point on the peripheral nerve injury is the higher the pressure, the quicker the problem. And that kind of makes sense, but you can't just say, I have 8 hours. If you see this, polytrauma come in, you really have to do that almost immediately if you don't want to prevent nerve injury. This is a nice picture of what Volkmann's ischemic contracture looks like. And the key muscles, like we talked about, are your deep flexors. So flexor digitorum profundus, when the compartment is scarred and it becomes fibrotic and it becomes shortened. So if you think of the position that that those muscles do, like the thumb will be bent down and then all the fingers and wrists will be flexed. The leg, again, it depends on the severity and in terms of what you're going to be left with in terms of nerve discomfort, pain, or the muscle weakness. And for example, that anterior compartment, you'll be seeing the potential foot drop. We talked about the crush syndrome and then the forearm complications as above. And then I would just mention, too, in terms of late reconstruction, It's just kind of a little bit out of this scope, but there are some different procedures performed where you can do a muscle slide, where you actually release your deep compartment muscles off the bone and let them slide distal to gain a little more function, or this is where you do your free muscle transfer with your gracilis. Medical legal implications are really high, and the awards are huge. So I think things to prevent this, you want to document everything. The thought process, you want to document your compartment pressures. This is completely apropos to me because a case I did 2 years ago is now in the court system, and fortunately my record is good and I have pictures and everything, but still it doesn't give me immunity in this case going forward. Significant financial rewards for missed full-blown compartment syndrome, and we're talking in the high hundreds of thousands into the millions. There's a decreasing trend of the compartment syndrome because of more awareness now that we have of it, education and people performing the procedure. Documentation, and this just kind of goes down into, talking about exactly what you see and then having those compartment pressures measured and listed in the chart. So you want to have a low threshold to check the compartments. It's basically you're just inserting a needle in, and that gives you a reliable indicator of what's going on inside there. If you think it might be, you should check it. The ones to remember, the buzzwords: tibia fractures, recently applied cast, reperfusion injuries, and then the missed compartment syndrome is devastating, and then you want to do that decompressive fasciotomy. So this is my case actually here at this hospital about 2 years ago. This is a 50-year-old woman, came in, she was having chest pain. She went to radiology for a CT angio. They put a catheter in her antecubital area here, and I think you can still see that right in this area here. And they started to inject the contrast, and she screamed, "It's not right, it's not right, it's not going in." And I think it was an auto injector. They didn't stop, and they did the auto injector of 60 cc's of contrast, which immediately perfused into the level of the subcutaneous tissue. And a lot of times, if it's not a lot, I mean, you see these, you guys, the nurses see this all the time with these extravasations. They're usually not a problem, but maybe it was just the irritant or the volume or the patient or a combination of all three. But she ended up having the study. Obviously, there was no contrast in the level of the chest, complained, went home. About 6 hours later, came back to the emergency room, screaming in pain, couldn't feel her fingers were cold, and now it's 2 o'clock in the morning, 3 o'clock in the morning, where I'm getting called to come in and assess her, and you can see the purple discoloration in the hand, the amount of swelling that she has, the forearm, which is tense, and then you can see this is where the betadine, where I did the compartment pressures in the emergency room. Volar compartment was almost 60, and it was about 40 on the dorsal side, so that 60 was worrisome to me, and especially with her clinical signs, made the decision to bring her upstairs and to perform the procedure. So this is kind of the laid out incision that I talked about, kind of the zigzag over here so I can mobilize to cover the median nerve, and then took it all the way back up and up the medial side of the arm. Then you can just see the kind of the shininess of her hand right here, and the early changes. And here's the dorsal incision to get the mobile wad, and then your dorsal compartment. This is after we released the dorsal compartment. I also went up onto the hand, and I released the interossei muscles and kind of felt around toward the thenar and hypothenar. Here's just an example of the open. I mean, and this is like a huge whack on somebody. So you can see that, the left untreated, it's devastating. Even if you do have to come and have surgery, there is going to be some scarring, and there's going to be some secondary issues just doing a procedure as extensive as this. So that's just your open wound. The compartments just kind of, when you cut that fascia, the muscle bursts out from underneath there, and then you can see, I don't know if this shows it so well up there, but you can see like kind of the end of the fascia right there as as how far it retracts back quickly. And then you can see the underlying tendons right there. Was able to close the dorsal side and just one stitch to kind of approximate the dorsal hand. And then here is that bootstrap kind of lacing technique that we do, where we'll use the stapler to kind of hold that in place. And then I did 2 of them. What you can do, like if you pull up on either side here, you can put more tension, or if you release this knot, if once you pull it up and you say, oh my God, I don't like the way this hand looks, you can just loosen the knot and then loosen this up to get the appropriate tension. And that would be the other thing. If she's up on the floor and she's really complaining of pain, or you don't like the way that hand color is, you can just come in and then at the bedside just release this knot, and then the whole thing will open back up. So, yeah, sorry. I should have warned you beforehand. I know. Well, they're not going to look. So, wet to dry over that. Yeah. I mean, the other alternative is the vac. The problem with the vac, though, I find like if that skin really retracts back, it's going to be hard to close it. And then they've kind of bought a skin graft, so now you have the cosmetic deformity on top of this as well. So that's it. I took this slide. This is down in our OR because we get this case and it always happens in the middle of the night, and then it's like a panic. So then the next step is where is the compartment syndrome kit? Where do I get it? I just called the ER doctor because I thought that they got one for the OR and one for the ER. The ER doctor said, no, we don't have one down here. So my understanding is that the only compartment measuring device we have is upstairs in the OR. And this is where it sits. So this is the close-up of it. This is the desk. Lori's going to be like sitting right here. So you go behind the OR. And again, you laugh, but you're going to be the one potentially getting this thing at like 11:30 at night. So you go back here, and it's this white box. This is the new one. This is the Stryker one that sits back there. And then there's also a black one which sits right down in here. And this is the accessory, the backup one, which is your Synthes. So that's it. And then if you guys want to come up, I'll show you how to use this thing here, and that's it.
Patients really tolerate you sticking that needle into their partner when it's like that?
Well,
They have to come here.
The only person I've ever done one is that guy that was out of it on floor.
Oh wait, that was
Yeah,
that was
we were there.
I
Free
can't
South
remember
right
the
now? There's one on Free South.
Is there?
He's got backs on it, yeah. Thanks, Lloyd.
Hey, if that